Well, good morning, everyone, or almost good afternoon at this point. It's a real honor to be here and a pleasure to present again at CRI. My last time here was 2009, and the conference is just fabulous. Congratulations to the conference organizers. I also wanted to thank Steve, Sanjay, and Michael, not only for inviting me to speak, but for also giving me about 2.5 times as much time to present as my colleagues. Either suggesting I have a lot to say or I just take a very long time to say it. Before going on, I also wanted to pause for a moment. I'm a sports medicine physician, and sports cardiology has really become a passion for me, but I couldn't be where I am today without the help of many individuals, and in this room are just so many people that I look up to that have taught me so much over many years. Domenico, Antonio, Sanjay, Mats, Michael, just thank you so much for your teaching and your mentorship over many years. Before lunch, what I hope to talk about is some of our cardiac screening updates within the United States and take a look into the future, perhaps, of what's around the corner. I come from Seattle, and I have the privilege of taking care of athletes at many levels. I work with the Seattle Seahawks, which also brings me into London this weekend. We play the Oakland Raiders in American football on Sunday at Wembley. I take care of University of Washington athletes, specifically our men's basketball team in track and field, and also take care of our professional women's soccer team in Seattle called the Seattle Reign. Just a quick stat, as you all know, about 3/4 of sudden death in athletes is from a cardiovascular related cause. And if you sit in my shoes as a sports medicine physician who is given the responsibility of ensuring athlete safety on the playing field, if we are serious about athlete safety, I don't think we can move forward with that without effectively screening for conditions at risk for sudden death. Cardiovascular screening has been debated for a long time, and it is this evolving puzzle of what is the best protocol. However, there is widespread agreement that early detection and screening is important. Effective prevention requires early detection of cardiovascular disorders at risk of sudden death, yet the best screening protocol remains controversial. And I think we're all looking for both a pragmatic and an evidence-driven screening strategy. This is sort of the classic ECG debate that for many years has been a transatlantic divide, with the European Society of Cardiology as well as FIFA and the IOC recommending ECG screening in their athletes, yet the American Heart Association strongly saying, no, we can't do ECG screening in our athletes, or maybe we shouldn't do ECG screening in our athletes. I'd also say that the debate now has turned more to a domestic issue. I think we have U.S. sports medicine organizations talking about ECG and wanting help to do better screening, yet we still have the American Heart Association saying that we shouldn't. And of course, all of our professional athletic associations require ECG screening on an annual basis. The continual focus, largely from the American Heart Association, on the problems of a national or federal and mandatory screening program has really diverted our focus away from the care of the individual athlete and guidance for the individual physician when we think about what the best screening protocol is. So I'll give you some summary recommendations up front, or the bottom line up front. The pre-participation evaluation as currently employed in the United States is not sufficient for cardiac screening. There is robust epidemiologic data that has defined high-risk athlete groups that warrant more intensive screening, and we need expanded sports cardiology infrastructure through education to deliver more advanced screening. The article in 2006 that was really landmark by Domenico and colleagues and published in JAMA began this discussion and debate about ECG screening. And I think that to look at this slide and talk about incidence and risk on athlete populations is really important. If we look at this, as we all know, before they mandated ECG screening in Italy, it's about 1 in 25,000 athlete risk for sudden cardiac death, and 25 years later, they demonstrated an 89% reduction in risk. In the US, the initial studies for incidence of sudden cardiac death came out in the mid and late 1990s by Van Camp and then by Marin. And their argument was that if our incidence of sudden cardiac death is already as low or perhaps lower than the incidence of sudden cardiac death in Italy after they have introduced ECG screening program, then why do we need to do ECG screening? And we'll come back to this in a little bit. As brought up by Anil, the methodology is really important when evaluating the scientific validity of the incidence estimates that we're looking for. In the United States, there is no mandatory screening program, and it's very difficult to compare incidence studies with profoundly different methodology. What's the geography and the age range of the study population? Are we talking about sudden cardiac death or all sudden cardiac arrest that includes both deaths and survivors? Is this occurrence of sudden cardiac arrest at any time or only with exercise? Are we talking only about school-sponsored events or those that occur outside of competitive sports, perhaps at sleep or rest? And then, of course, the methodology used for case identification varies greatly. And as mentioned, if we do not have a precise number of events or the numerator, and we don't really have a precise calculation of the denominator, then it's very difficult to calculate an accurate and reliable incidence. This is work led by my colleague Kim Harmon at the University of Washington. We've seen this slide a couple times looking at the frequency of sudden cardiac death in college athletes in the US in the NCAA, with cardiac-related sudden death being the most common medical cause of sudden death. And in this study, there were 79 cardiac-related deaths with over 4 million athlete years and an overall incidence of sudden cardiac death of 1 in 54,000 per year. But if we break that down further, males were higher risk than females. Black athletes were at higher risk than white athletes. If you were male and black, the risk was 1 in 16,000. If you're a male basketball player, the risk is 1 in 9,000 per year. If you're a Division I male basketball player, the risk is 1 in 5,000 per year. And a reminder, all of these athletes were screened predominantly with history and physical, and these numbers do not include sudden cardiac arrest with survival. If we look a little further into that data set, men's basketball in college sports in the US represents only 4% of our male athletes, but nearly 20% of all sudden cardiac death cases. And men's basketball and football together represent 23% of all male athletes, but 50% of sudden cardiac death cases. This is work that we published this past year, a 2-year prospective data set in collaboration with our National Center for Sports Injury Research, our National Federation of High Schools, and the NCAA, trying to monitor and collect all cases of sudden cardiac arrest and death in a competitive athlete, and this was review of a 2-year data set. And I'll just share with you a little bit of the information that was sport-specific about sudden cardiac arrest and sudden cardiac death. And again, basketball and football together made up 54% of our cases. And if you add in soccer and track and field, 75% of our cases were accounted for by 4 sports alone. So why is this so important? Why are we spending so much time on incidents? Well, the underpinning of the screening debate is centered around estimates of sudden cardiac death. And we must interpret the validity of the results based on the rigor of the methodology. And I think we need to recognize that the perpetuation of faulty science and misinformation, especially stemming from the US, has slowed the development and implementation of more effective prevention strategies. Let's take a look at an example of some of the faulty science. These were 2 authors that are friends of mine. They're sports physicians in the United States, Bill Roberts and Steve Stovitz, and what they did is they looked at high school athletes in the state of Minnesota. They identified cases of sudden cardiac death based on a review of catastrophic insurance claims in their state over 19 years. And they found 4 cases of sudden cardiac death and an incidence over 19 years of 1 in 400,000, and then an incidence in the last decade of their study of nearly 1 in a million sudden cardiac death. And this was published in a very high-profile journal, Journal of American College of Cardiology. And when I read this, I was like, is this true? Can this really be right? And so we researched and published a letter to the editor about this study. And we used the Parent Heart Watch database, which is pretty much just a database of media reports, collected cases of sudden cardiac arrest and death in the United States. We looked at the same 10 years as the last 10 years in that study using catastrophic insurance claims. So what did we find? We found 13 cases in high school athletes, 6 sudden cardiac death, and 7 sudden cardiac arrest, for an overall incidence of sudden cardiac death of 1 in 154,000. If you looked at all sudden cardiac arrest, it was 1 in 71,000. If we broke it down further, all 13 cases were in males for a risk of 1 in 37,000, and 6 of our 13 were in boys basketball, again a high-risk sport, 1 in 21,000. This is a far cry from 1 in 900,000, all based on the methodology of looking at that incidence. Other misinformation that we hear all the time, this is written by the lead author of the American Heart Association recommendations for cardiovascular screening in the US. Death attributable to cardiovascular disease in young athletes in the US occur at an annual rate similar to lightning strike fatalities. So let's look at real data. So this is information from NOAA, which is our government institution that monitors deaths from lightning strikes, and on average, you can see here. So let's look at the numbers. So on average, there are 32 lightning strike fatalities per year in the US. We have a population of about 320 million. That's a risk of 1 in 10 million. In other words, if we compare to a risk of 1 in 50,000 for a college athlete, the risk is 200 times greater that they die of a cardiovascular condition than die of lightning strike. And if we compare it to a male basketball player with a rough estimate risk of 1 in 10,000, the risk is 1,000 times greater that they die of a cardiovascular condition than die of lightning strike. So how can this be? And I want to introduce the concept of confirmation bias. What is confirmation bias? Confirmation bias is the tendency to interpret, favor, and recall evidence as confirmation of one's existing beliefs or theories. This is rampant right now in politics in the US, unfortunately. And it's also very true in how we look at sort of the history and evolution of the ECG debate. I know that I am guilty of this as I interpret data about risk, because I'm in favor of more aggressive screening and more prevention. But in general, people see what they want to see. So let's go back to that original graph from Domenico, where you can see the Italian athlete study in gray, and the yellow line is the risk of sudden cardiac death in a Minnesota high school athlete based on Barry Marin's research in the late 1990s, a risk roughly about 1 in 200,000 athletes per year. So let's put some other things on this graph. So this is the risk of sudden cardiac death in a college athlete, the risk in a male college athlete, the risk in US military males. Here's the risk of sudden cardiac death in a black male college athlete, which is very similar to the risk that Anil just presented in elite adolescent soccer athletes found here in the UK. Here's the risk of sudden cardiac death in a male college basketball player of any race. And here's the risk of sudden cardiac death in a black male college basketball player in the US. Now, to put this in some relative terms, the risk of sudden cardiac death in an elite adolescent soccer player, the relative risk is 15 times greater than the risk of a general high school athlete in the state of Minnesota. The risk in male college basketball athlete, the relative risk is 24, and the relative risk of 41 in a black male college basketball athlete. In medicine, we do very little that treats everyone the same. And I think we need to include risk to motivate how we screen individual athletes. And I think we know the answer to this question, is this enough? If we screen by history and physical, which has been the recommendation from the Pre-Participation Evaluation Monograph, which is a collection of societies in the US, or the AHA 14-point, or before that, 12-point evaluation, if we screen only by history and physical, will this be enough for effective prevention to identify those with predisposing conditions to sudden cardiac death? And we've heard some great data already, which points us in the right direction. This was my first experience employing ECG into our screening practice at the University of Washington for our college athletes. In 2008, after the publication by Domenico and colleagues, we started to think about employing ECG. We needed time to learn how to do it. We needed time for our cardiovascular group to get up to speed. We dipped our toe in the water by screening men's basketball and then football. And then in 2010, we started routine screening in all of our college athletes on matriculation to school, so about age 18. And I can say that just last year we began re-screening our high-risk groups as juniors, which include men's basketball, football, and soccer for a second time. But this is some initial data from 2010 when we look back, starting in 2010, just over 5 years of screening. So in those 5 years, we had 790 athletes, which represented a lot of sports with different races and of course, a balance in gender. Interestingly, if you look at history, 37% of our athletes checked one of the boxes on the pre-participation evaluation heart health history questions. That means 37% of athletes don't have a heart condition. So these are largely false positive responses. Our exam was positive in 3.5% and ECG abnormal in only 2.8%. We found 5 athletes with conditions related to sudden cardiac death, 1 with hypertrophic cardiomyopathy, 1 with long QT, and 3 with WPW, all found by ECG. If we only did history and physical as recommended by some authorities in the US, all 5 of those athletes at risk of sudden death or with conditions at potential risk would have been missed. More recently, we decided we needed to compare, and this is unpublished data, the performance of the AHA 14-point to ECG in the cardiovascular screening of high school athletes, and this comes from some of our foundation work out in the community screening high school age athletes, similar to what CRI does here in the UK. So in this study, we had 3,620 high school athletes. 45% have at least one positive history response on the AHA 14-point. 45%. And if you sit down with those individuals and try to sort out what do you think is clinically relevant versus not, still about 22% have some symptom reporting that's hard to completely disregard as benign. ECG was abnormal in only 3%. And we found 16 major cardiac conditions for a general prevalence of 0.5% of condition at risk of sudden cardiac death. Now the AHA 14-point identified 9 of 16, failed to detect 9 of 16 individuals, or the majority of individuals with at-risk conditions. But there's a caveat to that. The caveat is that we were doing the screening, and they all had ECG anyway, and they also all had echocardiograms. And in the community, I am not confident that a positive history response leads to an ECG and echocardiogram like it did in this study. But still, the majority conditions were missed. If all we did was ECG, we would have missed only 1 of the 16 conditions. If we combine the different screening studies that have been done in the US and published contemporary studies in the last 5 years, David Price looking at high school athletes, our work at UW, a multi-center study that we published in NCAA athletes, and then Colin Fuller's work from the University of Nevada in Reno. If we tally that up, there's about 9,000 athletes that were screened, 26 pathologic conditions. H&P would have identified 15%, and in these particular studies, ECG was positive in all 26. But in general, you get the message, and I think everyone would be in agreement, from a sensitivity standpoint, ECG is far superior than history and physical. This was a recent survey-based study that we published, just surveying the head team physicians at our biggest universities called the Power 5 conferences, asking about their screening practices, and I'll draw your attention to the right of the screen, looking at either all athletes or men's basketball athletes, with a minority using only history and physical for screening, and in general, 58 to 71% employing ECG already in the college athlete setting. So clearly there's added value to ECG, and I'm happy to report that the sports medicine organizations within the US are finally recognizing this. AMS SM, the American Medical Society of Sports Medicine, had a position statement that said history and physical exam lacks effectiveness, and the NCA stated that the history questions lack scientific validation. We produced a position statement from AMS SM in 2016, and I'm very proud of this work. On this panel were 10 sports medicine physicians, 6 essentially opposing ECG and 4 who conduct ECG in their practice. And the reason I bring that up is I really feel like this was a balanced assessment of our screening recommendations. The panel was not 100% for or against ECG going in. And we tried to reframe the debate away from should everyone get it and should this be a mandatory federal program, where the polarized options leave nothing in between to choose from, to try to come up with a framework or a paradigm that can guide the individual physician about how to screen the individual patient, much like we do in the rest of medicine. So this was a strength of rationale for ECG screening, a figure that we published from AMS SM, and I'll just walk you through this. And as you can see, 4 big categories to think about. Athlete risk, or the incidence, which we talked about in detail. The assessment of benefit to harm. I really believe this is a little bit about people seeing what they want to see. If you believe that early detection is going to be helpful, then I think you're more likely to be in the green side. And if you think early detection or the screening process is going to be harmful, if your false positive rate is super high, then you're going to be more in the red side. Resources is huge. If you don't know how to conduct ECG screening, you shouldn't be doing it. And it takes a lot of training and expertise to do it. And then you also need something beyond ECG. What happens for those with abnormal testing? You need quality cardiovascular evaluations with people who know how to interpret echocardiograms and other modalities that can truly distinguish between the pathological changes that we're looking for versus the physiologic changes in the athlete's heart. And then, of course, lastly, the requirements that within some of our professional leagues, perhaps college standards in the future, these will dictate what we do that is different than, let's say, athlete risk and our resources. If we look back just briefly at our 2-year data set, there were some interesting subsets that came from this. So we had 56 athletes with established, of 117 athletes who had died, 56% of the athletes had ECG detectable conditions. And if we break that down by race, 53% of the white athletes that died had an ECG detectable condition. 62% of the black athletes that died had an ECG detectable condition. 68% of our black basketball players had an ECG detectable condition. And 100% of our college basketball players that died had an ECG detectable condition. If we look at hypertrophic cardiomyopathy, it was present in 10% of our white males that had died, 30% of our black males that died, and 23 and 25% of our male basketball or football players that had died in this subset. So to put this shortly, ECG screening may be most effective in our highest risk groups with a larger proportion of cardiomyopathy and ECG detectable conditions. So we're stuck right now in the US. we have a huge infrastructure gap. On one side, we have history and physical that's been employed for many years, that's still cited by large organizations like the AHA as the thing to do. And you have the majority of the sports medicine community recognizing at least that H&P is insufficient. On the other side, you have expert centers, perhaps like the University of Washington, conducting ECG with a great cardiology team and performing arguably a better screen. But between that, a huge infrastructure gap that really calls for more education, training to close it. I'm very thankful to the collaboration, Sanjay, Michael, and others in the room on the development of the international criteria, which are really standards for interpretation of an ECG, which I think are being employed around the world. And this is a giant step towards bridging that infrastructure gap to guide ECG interpretation in athletes. With that, coming very soon is training modules related to the international criteria in ECG screening. With the Seattle criteria, we produced a training module within BMJ Learning, which is still up and running and still very valuable. For the international criteria, I've been collaborating with the Australasian College of Sports and Exercise Physicians and our center. We have 6 very nice modules that will be launched, I would predict, hopefully in the next month. These will be freely available for anyone around the world to take and will be part of a larger e-academy where we'll also have conference presentations just as a sports cardiology resource to try to get people up to speed. Another new thing that we're doing in Seattle is using telemedicine, trying to be innovative about how we can bridge that infrastructure gap. So this is not having the physician conduct ECGs, but to have the athletic trainer or the physio in the high school do the ECG, send it to us electronically, we'll interpret it and get back to them, not just with a normal or abnormal result, but if the ECG is abnormal, give them specific recommendations on what to do next. One other thing that's happening within the US right now that I'll bring up and is worthy of more discussion, we've heard a little bit about it this morning already, is sort of a paradigm shift in the decision-making for athletes identified with disorders at risk for sudden cardiac death. What colleagues and friends of mine are talking about is the shared decision-making model for whether or not that individual returns to play or not. And I would say that this has been largely substantiated and validated in our ion channel disorders like CPVT and long QT. But that same data does not exist for our cardiomyopathies thus far. And personally, I am still concerned about a general theme that's occurring, allowing patients with hypertrophic cardiomyopathy return to play. This was true and presented by the great work done here in the recent New England Journal paper, and Anil talked about this a little bit. I'll draw your attention to the left of the screen, and something that spoke very loudly to me in this particular study is the 5 individual athletes at age 16 who were identified with hypertrophic cardiomyopathy. 3 of them stopped play and survived. 2 of them returned to play against medical advice and died. And as we all know, no matter what we employ in screening, whether or not we do ECG, whether or not we do ECG, echo, maybe even CMR, no matter what screening protocol we do, it's not perfect. And we must be prepared to respond to athletes in sudden cardiac arrest. This was data we just published on survival after exercise-related sudden cardiac arrest in young athletes in the US. This was from that 2-year data set in collaboration with the National Center for Catastrophic Sports Injury Research. Our overall survival rate was 48% in 132 athletes with sudden cardiac arrest, and was best in our Division I NCAA programs with 75% saves. 93% of these cases were witnessed. If an athletic trainer was on site, survival was 83%, and if an AED was on site, survival was 89%. So you might be thinking, well, 48% survival, that's pretty good. If you look out in the community in the US, overall survival is about 10% or less. So is 48% good? Is it good enough? To me, it's not good enough, and I'll explain why in just a second. It's about half of what we should be doing. The other finding from our study is that there's a real disparity. If you were white, you were twice as likely to survive sudden cardiac arrest than if you're African American or non-Caucasian. So what is the survival after sudden cardiac arrest that we can achieve if we're prepared and we have proper equipment close by? In 2013, we published data from our AED registry looking at survival. There were 2,100 high schools followed for 2 years. This was a prospective study. 87% of our schools had an AED program. In 18 student athletes with witnessed sudden cardiac arrest who received prompt treatment, we had an 89% survival rate. And initially when we published this, I was like, wow, is that too high? Do we look at our data correctly? You know, what happened? Because that's really an incredible survival rate. Just recently in the New England Journal of Medicine, a research correspondence letter discussed survival rates in 28 runners with witnessed cardiac arrest in Japan. These were mobile AED units who got to these athletes quickly. A mean time to CPR, less than a minute. Mean time to AED shock, only 2.2 minutes. 100% survival in that group. And then also the study at the bottom, looking at fitness centers in Italy, 26 cases of exercise-related SCA. For the fitness centers with an AED, there was 93% survival, and if your fitness center did not have an AED, only 9% survival. So the message is clear. Sudden cardiac arrest in athletes is largely a survivable event if you recognize it quickly, are prepared to respond, and there's an AED close by. I personally think we need to do a better job at that, and sort of cleaning up our backyard and making sure we're prepared before we talk more about screening. But there really should be a universal response to a collapsed athlete. Too many athletes collapse in sudden cardiac arrest and are not treated for cardiac arrest because of distractors, brief seizure-like activity, agonal respirations that are misinterpreted. Agonal respirations look like chest and abdominal movements or gasping, and if you're a lay rescuer or a coach, even though there's an AED on the back wall, you don't get it because you think they're breathing or you think they're having a seizure. So in a non-traumatic collapse, if the person is unresponsive to verbal stimuli, I think the protocol should be simplified. Call for your emergency help, begin chest compressions, go and get the AED, apply, and use it as soon as possible. So to summarize some cardiac screening recommendations in the US, these come from me. I think we need to be more proactive to develop sports cardiology infrastructure to screen more effectively in the US. High-risk athletes, which I would define as male basketball, football, and soccer, should undergo ECG screening every 2 years, and if my colleagues are not already doing it, I think they need to work very hard to quickly create their local infrastructure to do it. All other athletes should be offered ECG if the resources and expertise are available. In my clinic, I screen everyone with ECG. If you come to see me for an ankle sprain, I might screen you with ECG because I want to do it. But I think we need to be aware that the infrastructure is not available for everyone, and who we screen may be largely influenced by our resources and our expertise. And then, of course, we need universal AEDs and proper training to recognize cardiac arrest as soon as possible. Thanks very much for your attention.